All right, so officially, thank you all for joining today's T32 Pediatric Clinical Pharmacology lecture series. It is the first lecture of 2026. So I hope you all had a great holiday season and wishing you all a happy new year. So I'm really excited to kick off our winter and spring session with the help of Imprint. I am very appreciative of all of Emprint's assistance as we move into our winter and spring session. So just as a quick reminder, please feel free to place any of the questions for our speaker in our Q&A box or in the chat, and we'll go ahead and get started. So it gives me great pleasure to introduce our speaker for today, Dr. Laura Ramsey. Dr. Ramsey joined Children's Mercy in 2023 as the Section Chief of Individualized Therapeutics in the Division of Clinical Pharmacology, Toxicology, and Therapeutic Innovation, and is the co-director of the Pediatric Clinical Pharmacology Fellowship Program that's at T32 funded via NICHD. She is leading the implementation of a pharmacogenomics program that is fully integrated with the electronic health record, and she's developing model-informed decision support for several medications. Now, before joining Children's Mercy, Dr. Ramsey was at Cincinnati Children's Hospital Medical Center as an associate professor, co-director of the Genetic Pharmacology Service, and co-director of the Clinical Pharmacology Fellowship Program. She has completed her postdoctoral fellowship in pharmacogenetics from St. Jude's Children's Research Hospital and received her PhD in molecular, cellular, developmental biology and genetics from the University of Minnesota, Twin Cities. Dr. Ramsey has an interest in all aspects of pharmacogenetics, from basic research to implementation and patient care. She has led projects to study pharmacogenetic variants that influence response, toxicity, and dosing of antidepressants, immunosuppressants, and chemotherapy in children. She has authored over 100 peer-reviewed manuscripts, hundreds of abstracts, presentations, and is extramurally funded, including a National Institutes of Health R01 award. So please join me in welcoming Dr. Ramsey.
Thank you, Leslie, for the very long introduction. I'm sorry I made you read all of that, but I appreciate that. So today I'm going to be talking about pharmacogenetics in child and adolescent psychiatry. And all right, so you've seen my disclosures already on the opening slides as well as the learning objectives. So I'll start with a description of the variability in response. So kids treated with an SSRI, you expect to respond, and on average, they respond a little over 20% improvement over 12 weeks. And it's not the average patient that is coming to your office as a psychiatrist, though. It is a individual that's shown here by these individual lines. So there is quite a lot of variability around that average response of 20% over 12 weeks. So you never know if the patient that you're treating is going to be this one that's responding 40% improvement or this one that is about 5% over 12 weeks. And so it's really a guessing game as to how a patient will respond. There are a lot of things that contribute to the variability in this response. And some of those are the age, the sex, weight, the clinical factors, the environmental factors as well, what's going on at school, what's going on in the home situation, adherence. And so, but pharmacogenetics is part of that variability. So the variable exposure is the pharmacogenetics does contribute some to that. I like to explain this with a bathtub analogy. So giving a dose is like turning water on at the same rate in all patients. And the metabolizer group is like the size of the drain. So if you're a poor metabolizer, you have a very small drain and you are likely to overflow the bathtub with high concentrations and a high risk of side effects. As you increase your metabolism speed for that drug, then the bathtub drain gets bigger until you get to be an ultra rapid metabolizer where you're more likely to have no water in the drain or low concentrations and a high risk of non-response. Now, this analogy really only holds for active drugs that are inactivated by their pharmacogenetic metabolizing enzyme. But another aspect to consider is a drug interaction, and that inhibitor of the drug metabolizing enzyme is kind of like hair in the drain, where it can make you go from a genetically normal metabolizer to phenotypically a poor metabolizer, which is something we call phenoconversion, and I'll talk more about that later. And I don't want to seem like somebody who's going to say pharmacogenetics is useful all the time, because it is not always useful. So on the left here, we have a drug that has a narrower therapeutic range than on the right. The association between the drug metabolizing enzyme and the drug concentration is the same in both graphs here. But when the therapeutic range is more narrow, this association puts a lot of the poor metabolizers outside above that therapeutic range, and the ultra-rapid metabolizers are more likely to be below that therapeutic range where you would expect less response. When the therapeutic range is bigger, then the association can be the same, but you wouldn't expect much of an improvement in dosing or based on pharmacogenetics, an improvement in your outcomes based on using pharmacogenetics to guide dosing. So in this situation on the left, you probably would expect pharmacogenetic guided dosing to help reduce adverse events that are caused by high concentrations or non-response caused by the low concentrations in these ultra-rapid metabolizers, but not so much on the graph on the right. So one of the things that I'd like to make sure that everybody here has that knows, you all know about, is CPIC, which is a NIH-funded organization that provides peer-reviewed guidelines that are updated regularly and freely available for gene-drug pairs. And their goal is not to say when to test, but to really facilitate the translation of pharmacogenomic knowledge into the clinic so that clinicians know what to do with the genotypes when they are available to them. There's also a similar organization in Europe, the Dutch Pharmacogenetic Working Group. There is, of course, pharmacogenetic information on FDA labels, and I'll show you one of those later. And ClinPGX is a newer resource. So PharmGKB was kind of the hub that contains all of this information. And it's recently transitioned to be ClinPGX that includes CPIC as well as PharmGKB in one website. So clinpgx.org is kind of the first stop for any pharmacogenetic information. You can look up individual drugs, you can look up individual genes and really see the level of association. They've curated all of the literature for each gene drug association and even down to the variant level. PharmVar is another great resource housed here at Children's Mercy, where the allele definitions are provided. So that is what a lot of the guidelines above are based on. All right, so now I'll jump into talking about some of the evidence for pharmacogenetic associations with pharmacokinetics in child psychiatry. So I'll tell you about this study that we had collected samples from when I was at Cincinnati Children's. Every one of the patients that's admitted to the inpatient psychiatry unit at Cincinnati Children's that has about 100 beds is tested for CYP2D6 and CYP2C19. They also usually receive a CBC, and so I would get a notice that one of 5 medications had been prescribed while the patient was inpatient, and then CBC was done just after that, within 24 hours. So I could go pick up the remnant blood sample from the lab and spin it down and put it in the freezer until we were ready to measure the concentrations. So the genotyping was done as part of standard of care clinically. The um, drug concentrations were measured, and then we could look in the electronic health record for the dosing history and some of the clinical covariates that we needed for modeling. And then we put this information into MW-Pharm, which is a PK modeling program to really fit the individual patient's data, and then simulate that at a common dose across all the patients that got that drug. So like escitalopram at 15 milligrams or sertraline at 150. So like I said, we did this for 5 drugs and collected over 1,800 samples over a few years. 2/3 of them were from females because these drugs are prescribed more often to females than males, and they're pretty standard distribution of ancestry or race that reflects the Cincinnati area. The median age was 15, and we had over 600 samples for escitalopram and sertraline because we started those 2 drugs first, and then a good number of risperidone, aripiprazole, and fluoxetine samples as well. And on the right here, you can see the distribution of the CYP2C19 and CYP2D6 phenotypes, where about 40% of the patients are normal for CYP2C19, which is what you would expect based on this ancestry, and about 50% for CYP2D6. So if you multiply those together, that means a little over 20% of the patients had normal phenotypes for both of these genes. 80%, therefore, had at least one non-normal phenotype. So most patients have a phenotype that might be informative for dosing psychotropic medications. The first one I'll go through here is escitalopram. So escitalopram is the S enantiomer of citalopram, and citalopram is the racemic mixture of the R and S enantiomers. Both enantiomers are metabolized by CYP2C19 into inactive metabolites in the liver. And when we did this estimation of what the trough concentration would be if the patient were administered 20 milligrams a day, we found that every one of the poor metabolizers was above that therapeutic window that you can see here with the gray dotted lines. And some were approaching that concern threshold. Now, these thresholds are defined in adults and not in children, so we have to remember that. But we know that from previous studies, poor metabolizers are 3 times more likely to discontinue escitalopram than normal metabolizers. And the ultra-rapid metabolizers, who are down here closer to the bottom of that therapeutic window, are twice as likely to discontinue the medication than the normal metabolizers. You can see there's still quite a distribution even within the groups, but you see the expected association with higher concentrations in the poor metabolizers, and intermediate metabolizers have concentrations in between, or the median is in between normal and poor, and then the ultra-rapid metabolizers have the lowest concentrations. So this is one of the situations where it's more similar to the problem side of the graph I showed you earlier, where the poor metabolizers are outside of that therapeutic window and could benefit from genotype-guided dosing. Another prospective study that I did with Dr. Strawn at the University of Cincinnati showed the similar association where this was a prospective randomized trial of escitalopram, and pharmacogenetic testing was done after the fact. But this patient, who was a poor metabolizer, was only able to tolerate a few doses before he had to discontinue due to side effects. So it really shows that these high concentrations or area under the curve is associated with side effects. And the other thing we looked at in this prospective study was activation. And that was experienced by 5 patients who were part of the study and had drug concentrations. And we found that they had slower clearance of escitalopram than the patients that did not have activation, though again, there was quite a distribution. In this same study, we analyzed the outcome with the Pediatric Anxiety Rating Scale score, and that showed that the intermediate metabolizers, who on average had higher concentrations, got better faster and with a larger magnitude of response. So this really helped illustrate to us that perhaps the pharmacogenetics could be helpful in guiding the dosing in adolescents. The CPIC did publish a guideline for these 5 genes and serotonin reuptake inhibitor antidepressants. And there are quite a lot of authors included in there and quite a lot of drugs and genes. But the first one, so what they said about escitalopram was just what I showed you. The CYP2C19 activity, ultra-rapid metabolizers have low concentration dose ratios, and CPIC recommended that you use a higher dose or avoid this medication. The poor metabolizers have higher concentration dose ratios, and they recommend a 50% dose reduction. When we did some PK modeling of an adolescent and changed only the phenotype, we found that at 20 milligrams, those poor metabolizers would be very close to the top of that therapeutic range, and the ultra-rapid metabolizers, their trough concentrations are below that therapeutic range. So illustrated again what that would look like at different doses. And when we tried to estimate what doses would provide equivalent exposure, you can see that a 50% dose reduction, which is what CPIC recommended as well, showed equivalent Cmax to the other phenotypes, a bit higher trough concentration, but that's within the therapeutic range. And then the ultra-rapid metabolizers, we modeled a 50% dose increase, so 30 milligrams a day instead of 20. And you can see that their trough concentrations are still below that 15 nanograms per mil therapeutic range. So we designed this trial that is ongoing, funded by the NICHD. Thank you for that. Where we are enrolling adolescents with anxiety disorders, doing pharmacogenetic testing, and then randomizing to either CYP2C19 guided escitalopram dosing or standard escitalopram dosing. And the patient is blinded, the physician is blinded, and the study team is blinded except for the investigational pharmacist, who is the only one that knows what the dose of the medication the patient is getting is, because the capsules are over-encapsulated, so they can't see what they look like. So this is a 12-week trial. We're measuring blood concentrations twice throughout the study. We are again measuring efficacy with the Pediatric Anxiety Rating Scale and tolerability with weight measurements as well as activation. I'll switch gears a little bit to sertraline, which is influenced by multiple CYP enzymes. CYP2C19 seems to play the biggest role, but CYP2B6 also contributes some, and CYP3A4 is involved as well in metabolizing sertraline, the parent drug, the active drug, into an inactive metabolite. And when we looked in our opportunistic sample patients, we found that the sertraline concentrations were again highest in the poor metabolizers. The therapeutic window is bigger for sertraline than it is for escitalopram. So when we modeled this at 150 milligrams a day, which is a pretty common dose, but not the maximum dose that a patient could receive, we saw that the poor metabolizers had 3 times higher average concentration than the normal rapid and ultra rapid metabolizers. There was no difference in the normal rapid or ultra rapid, so we grouped them all together here. But you can see there's still a lot of residual variability here. And there is a group in Europe that has looked at this across patients that have had therapeutic drug monitoring. These are mostly adult patients. The concentration of sertraline normalized to 100 milligrams a day dose is on the y-axis. The CYP2C19 phenotype is here along the x-axis, and they are grouped by the CYP2B6 phenotype across the top. So this group that is poor metabolizer for both CYP2C19 and CYP2B6 is very near the top of this therapeutic range, again, identified with the dotted lines. And as you increase the speed of the CYP2B6, then this average concentration decreases, even amongst the CYP2C19 poor metabolizers. If you're poor metabolizer for both, the concentration is pretty close to the bottom of the therapeutic range, and so probably need a higher dose. You may need a higher dose to achieve those concentrations. So CPIC has guidance for the individual genes by themselves, where they recommend lower starting dose, slower titration, and 50% reduction in the standard maintenance dose compared to the normal metabolizers for CYP2C19, but also recommendations for when you know both CYP2C19 and CYP2B6. So the recommendations for those patients that are rapid or ultra rapid for CYP2C19 and ultra rapid for CYP2B6 are to titrate higher and faster, and then if there's no response, then switch. The patients that are poor metabolizer for CYP2C19 start low, titrate slowly, hoping to get to about 50% of the usual dose. So this is kind of like a bingo board where you have to find the right combination to find the recommendation. So with escitalopram and sertraline, these are both CYP2C19 metabolized medications. The recommendations are to start low and titrate slowly. If you're a faster metabolizer, rapid or ultra rapid, you really want to titrate more quickly to get to something that might be therapeutic. They will likely need higher doses than normal. And for sertraline, our PK modeling suggested that was about a third higher, so 200 milligrams instead of 150, or for escitalopram, a 50% increase because CYP2C19 has a bigger effect on escitalopram than on sertraline. All right, fluoxetine is another one that is commonly prescribed to children and adolescents, but there is conflicting or inconclusive data regarding CYP2D6. Fluoxetine is also a strong inhibitor of CYP2D6 and can make a normal metabolizer resemble a poor metabolizer. This is one of the situations, like the graph on the right that I showed you earlier, where there is a significant association with CYP2D6 for the drug concentrations, but both fluoxetine and norfluoxetine are active drugs. And so it's usually the total of this plus this that is used for like therapeutic drug monitoring when that's done, for instance, in Europe, or guiding the dosing based on the pharmacogenetics. So when you add those together, there may not be an association with CYP2D6, or there wasn't at the time of the CPIC guideline. So CPIC had no recommendations, but did suggest an alternate SSRI for CYP2D6 ultra-rapid and poor metabolizers, because we just don't know what the ratio, the effect of having a different ratio. It was clear there was a different ratio of fluoxetine to norfluoxetine in the ultra-rapid and poor metabolizers than the normal. But we don't know what effect that will have on the patients, as far as adverse events or clinical response. So in the Cincinnati cohort, where we had quite a lot of pharmacogenetic tests done as part of a standard of care, we found the same proportion. Only 22% had a normal metabolizer for both just CYP2D6 and CYP2C19. So that's not even considering a CYP2B6 that might be helpful for sertraline. So more patients are not normal than are normal. And these frequencies, they are variable by genetic ancestry. So in this graph, when the Americas are the same color, that means those who are native to America, not those who live there now, who have ancestry that shows that they're native. And in this graph, the darkest color is the ultra-rapid metabolizers. So for CYP2C19, you can see there's a lot of rapid and ultra-rapid metabolizers in those of European ancestry. And in Asia, you can see quite a lot of poor metabolizers. That's this lightest color here in people of Asian ancestry. The same goes for CYP2D6. The frequency varies across the global populations, where those native to Australia have quite a lot of CYP2D6 duplications to make them ultra-rapid metabolizers, where those are much less frequent in other areas. And sub-Saharan Africa, less than 50% are normal metabolizers. There are quite a lot of intermediate metabolizers in that population. So now I'll talk a little bit about CYP2D6 and risperidone, which is an antipsychotic medication, and a study that we did in African youth. We consented patients receiving risperidone for their standard of care at a hospital, a psychiatric hospital in Lagos, Nigeria, and we got a blood sample at their normal clinic visit. We were able to enroll over 200 patients, more males than females, because the risperidone is prescribed to more males than females. The mean age was about 12, and the CYP2D6 metabolizer phenotypes were what you would expect based on that last graph that I showed. And the risperidone was measurable in 133 of these 211 patients, but the 9-hydroxyrisperidone that has a longer half-life was measurable in 198 patients. So when we plot the log of the parent to metabolite ratio here on the right, you can see that the poor metabolizers have a very high ratio. This is another situation where both the parent and the metabolite are active drugs. The metabolite is 9-hydroxyrisperidone, and that is also prescribed by itself as paliperidone. So both are active, but they do have different side effect profiles. So these poor metabolizers have higher parent than metabolites because they're not making any. The ultra-rapid metabolizers have more of that 9-hydroxy or paliperidone. And you can see that intermediate metabolizers sort of had similar similar medians. Here you can see when I get rid of that. And so that made us question, like, what is going on with these intermediate metabolizers? Why aren't they more in between the poor and normal metabolizers? And when we looked at the carriers of the star 17 allele, you can see that those that have 1 are in the purple, and those that have 2 are in the orange. Most of them are in the bottom half of this intermediate metabolizer group, while the patients that have 0 are more towards the top. So it was kind of like there were 2 different groups within this intermediate metabolizer group. And so what we did was to kind of test the star 17 allele by itself when we calculated the relative activity to the alleles with that activity value of 1. We found that the star 17 allele had more than twice the normal function the star 1 and star 2 alleles had. And the star 29, which is also considered to have 0.5 activity value, had almost none, similar to those with a 0.25 or a 0. And this wasn't the first time that this was described. 20 years ago, there was a publication that had 3 patients that had a null allele with a star 17 allele that showed that this star 17 allele had higher than expected risperidone metabolism. So this kind of confirmed that finding from the past, but also we were able to confirm it in a separate cohort of kids with the remnant blood samples from Cincinnati Children's, where we had 12 star 17 allele carriers that showed an even higher metabolism capacity compared to the star 1s. And the star 4 and 5 had very little activity. There were a lot of patients on inhibitors in this cohort. So fluoxetine, bupropion are the most common ones. And you can see that had quite a significant effect on the ratio or the CYP2D6 estimated activity as well. So the current activity value of 0.5 for the star 17 allele with respect to risperidone might not be appropriate. And the reason that might be is because the star 17 allele has these 3 variants that are close to the drug binding pocket. So this T107I one here comes in pretty close contact. This is not risperidone that's shown in the drug binding pocket, but another drug. But it comes pretty close to where that drug might sit. And it's also higher stability in vitro with this star 17 allele. So it might be more stable, there might be more of it, and it might be interacting with the risperidone itself. And that's why it might have this specific activity for risperidone, because the literature is pretty clear that this allele does have decreased function for a lot of other drugs. So there does seem to be significant substrate specificity for the star 17 allele. The star 29 allele had very little activity, and we replicated that in the Cincinnati Children's cohort as well. And I think there could be significant harm by continuing to use the current activity scoring system for risperidone, because you may be underdosing the patient that you think is a intermediate metabolizer when they have a star 17 allele, but they might have increased production of the 9-hydroxyrisperidone, which has increased hyperprolactinemia risk. So we may need a different interpretation of genotype to phenotype for risperidone compared to other substrates. Now, the example here is a patient with a star 1, star 17 that could be translated as an ultra-rapid metabolizer based on our data instead of normal. A star 4, star 17, if you give the star 17 allele activity value of 2, could be a normal instead of intermediate. And if you have a duplication of the star 17, you could actually be an ultra-rapid metabolizer even if you have a null allele with that instead of an intermediate metabolizer that they would currently be categorized as. So we're working through this on the CPIC guideline committee for the antipsychotics at the moment, and realize that this could provide quite an issue for people who use the clinical decision support in electronic health record based on phenotype. There'd have to be some rules that are based on the diplotype instead. And I think this underscores the idea that really understanding the allele function with individual substrates is important. And the only way to do that is to study diverse populations. So I'll go through some drug-drug gene interactions as well. I described this as like hair in the bathtub earlier, or some of these strong inhibitors can be like Chewbacca took a bath in the bathtub. So they can really inhibit, change the concentration of other CYP2D6 substrates quite significantly. The moderate and weak inhibitors change the concentrations or exposure less so. But some of the other things that you might have to think about with the psychiatry population is the use of cannabis, which can inhibit CYP2C19. Here I'm showing the data from another European therapeutic drug monitoring study, where you can see the risperidone dose or aripiprazole dose across the bottom and the concentration. This one looks at the risperidone plus the 9-hydroxyrisperidone concentrations. There's a clear dose exposure relationship, but you can see that those patients that are normal or ultra rapid have more concentrations below the therapeutic range, here shaded in gray, than the patients that are intermediate or poor metabolizers. And the poor and intermediate metabolizers are more likely to have higher than expected concentrations. And this goes for both aripiprazole and risperidone. When we looked in kids at Cincinnati Children's, we found that in addition to the association between CYP2D6 and aripiprazole concentrations, we looked at the presence of a strong inhibitor and found that when we do the standard phenoconversion of multiplying that activity score by 0 for a strong CYP2D6 inhibitor, almost half of the patients prescribed aripiprazole were then phenoconverted to that poor metabolizer. And these patients were more likely to discontinue the medication than those who remained normal metabolizers. Both these are active metabolites again, so the drug concentration that's monitored is usually both the aripiprazole and the dehydroaripiprazole. But this one shows up in the FDA label quite a few times. So in the dosage and administration section on the first page, you see down here, there's a bullet point right under this dosage that known CYP2D6 poor metabolizers, you should administer half of the usual dose. It also shows up in the drug interactions on the first page of the package insert, where it says for known CYP2D6 poor metabolizers, administer half of the usual dose. And those taking strong CYP2D6 inhibitors administer half of the usual dose. And the study I described previously, where we looked at the discontinuation for aripiprazole or Abilify, the dose was not different among the CYP2D6 metabolizer groups. So that was why there was more discontinuation in those that were either known genotypically poor metabolizers or phenotypically converted to poor metabolizers. This also shows up later in section 7.1, where it says strong CYP2D6 inhibitors, e.g. quinidine, fluoxetine, and paroxetine, you should reduce the dose. And then just immediately after that, 7.2, it says no dosage adjustment is necessary for substrates of CYP2D6 like fluoxetine and paroxetine. So I imagine that can be a little confusing for clinicians, but I would say that the data shows that in the poor metabolizers, whether they are prescribed fluoxetine or paroxetine or not, reducing the dose is helpful. And this is also going to be included in the CPIC antipsychotic guideline that should be coming out this year. All right, so on a lot of the commercial pharmacogenetic tests are pharmacodynamic genes, and these are the target of the SSRIs. So the SLC6A4 serotonin transporter has a 44 base pair insertion that determines whether it's a long or a short form. And then there's also a SNP that affects the expression of this. The HTR2A is the other commonly tested variant. And this is on the other side of that synapse. And if you look at the paroxetine plasma concentration, this is an adult study from several years ago, and depression improvement on the y-axis, you might say, like many psychiatrists have told me, there is no concentration response relationship. And that's pretty obvious from this graph. But when you break it down into those who have the short allele and those who have at least one copy of the long allele of SLC6A4, the drug target, you can see opposite significant relationships. These SS patients respond very well at the lower doses or lower exposure, and the L allele carrying patients need a higher exposure to have that better response. There's still quite a lot of variability here, don't get me wrong, but there are significant relationships shown in this study. So how do we explain that? Well, the long allele patients here, the SLC6A4, the transporter, is shown in yellow. And on the left side here, we have two on this one neuron, and the short allele carriers, they have one because it affects the expression and how that gets to the synapse where it needs to work. So when you give an SSRI, you lower dose or lower exposure, you can see that hit all of the targets here in the SS patients, and they have a good response. It hits half the targets in the L allele patients, and they have a moderate response. And then when you increase the dose, then you hit all the targets in the L allele patients and have an improved response. But when you increase the exposure in the S allele patients, you have off-target effects, and that might be seen as less of a response because a lot of the symptoms and of the disease and the SSRI side effects kind of overlap. So you can think of pharmacodynamics sort of as the size of the bathtub. If you have the L allele, then you have a bigger bathtub that needs to be filled. You need more exposure. If you have the S alleles, then you have a smaller bathtub and you might respond at a lower dose. This gene has been quite extensively analyzed in the literature, but it's still not included in a CPIC guideline because there is quite mixed evidence. So you can see in these studies that there are quite large error bars here, and that overall in white patients with major depressive disorder, there is an association between or a difference in response between those who have one L allele versus those that have two S alleles. But this combines all SSRIs together, and it's a little bit different for patients that are white versus those that are of Asian ancestry. There's no association there. So that brings a little skepticism into this. Nevertheless, the companies that test for this gene will advertise to you that they can use this variation in SLC6A4 to tell you who might be less likely to respond to SSRIs. And they tell you to look at this section of the report where it says the SS patient might have reduced response. But I just showed you that response was dependent on the drug concentration. So none of those studies on the last slide in the meta-analysis really accounted for the pharmacokinetics or the pharmacogenetics of the PK genes when they did that analysis. So for that reason, there is no CPIC guideline for pharmacodynamic genes. There may be a class effect with SLC6A4 and SSRIs, which is why the commercial testing companies often put a recommendation that SSRIs be avoided in SS patients. But most of those studies that they use to make that recommendation don't account for the dose or the exposure, or they don't have enough power to analyze individual drugs. And so we couldn't use that in the CPIC guideline for those reasons. Also, part of the CPIC guideline is you have to know what the alternative would be. And for SLC6A4, if we're going to recommend against SSRIs, we need to know what the SLC6A4 short patients might, how they might respond to non-SSRIs, to SNRIs, or what the alternative would be. And there are no trials of using the SLC6A4 for drug selection, so it wasn't possible to say that they might respond better to another drug. All right, so how do you apply this in practice? We recommend that you first determine whether pharmacotherapy is warranted with an exam, and then select the medication that you want to prescribe to the patient based on the evidence for the disorder being treated. So make your medication selection first, and then think about, does this medication have actionable pharmacogenetic guidance? If that answer is yes, then you would consider pharmacogenetic testing, and make sure that that test includes CYP2C19, CYP2D6, and CYP2B6 if you're considering SSRIs. For carbamazepine and oxcarbazepine, you want to consider some of the HLA alleles also. And then once you get this information back, you can start the dosing before the pharmacogenetic results come back. But once they do come back, you might have to think about titrating differently, or some increased monitoring. And there's quite a variety of pharmacogenetic testing options out there. This was a survey I did quite a few years ago now, where there were 11 different tests that I looked at. They all tested different things, except for CYP2D6 and CYP2C19. Those are tested on every test. And quite a lot of them include genes that have very low evidence for use. And these evidence levels and the genes tested have changed since this assessment was done several years ago. But even more recent assessments that have done this have shown that a lot of the commercial testing companies include genes that have very low levels of evidence. However, the accuracy of the variants that they do test is regulated by CAP and CLIA. So you can be sure that if they said that the patient has this variant, that they do indeed have that variant. But what they test for it in each gene is very different. And how they interpret the genetic variants to the metabolizer status is not regulated and varies. And also how they interpret the variants or metabolizer status to the effect on the medication is very variable. So if you sent one patient sample to 5 different of these testing companies, you would receive 5 different results and recommendations. One of the things I'd like to stress is that just because a drug is a substrate for an enzyme doesn't always mean that genetic variants in that gene influence response or toxicity, and that more genes does not equal a better test, because many of these tests include genes with very low quality evidence. So this is another example of what a test result you might get back. It has pharmacokinetic genes, pharmacodynamic genes. This one says for short that it is reduced expression, but for HTR2A, increased risk, but they don't tell you increased risk of what. This is another commercial pharmacogenetic test that bins the medications into use as directed, moderate gene-drug interactions, or significant gene-drug interactions. And it doesn't really tell you how to dose them until you look at these little numbers next to each of the drugs to say the serum level may be too low, higher doses may be required. But for these SSRIs, which are the most commonly prescribed ones in kids, 2 of the most commonly prescribed ones in kids, the genotype may impact drug mechanism of action and result in reduced efficacy. So that's the one that's based on that SLC 684. They put it in this moderate gene-drug interaction category. Another thing to be wary about is how they interpret the genotype to phenotype. So this is another commercial test that uses the star4, star41 CYP2D6 phenotype and says that that is a poor metabolizer. But according to CPIC, this would be an intermediate metabolizer. So this is where you really have to be careful in that genotype to phenotype conversion. You can't just even look at the metabolizer status over here and trust that. You have to actually look at the genotypes. When this commercial test was used in a randomized controlled trial of adolescents with MDD, they looked for differences in tolerability at 8 weeks and 6 months and found no differences. So it didn't help at all in response or tolerability. But what they did show was that there were different medications prescribed. So more prescriptions of atypical antidepressants and SNRIs that are not really widely used for MDD, and less prescriptions of SSRIs, which are the first line with the highest level of evidence. So there is a lot of guidelines available from CPIC, DPWG, and FDA, and a tool that you can use to get unbiased information and recommendations that includes all of those guidelines is Sequence to Script. It also takes into account the current medications and phenoconversion. And you can put in the medications that you are considering, and it'll give you those recommendations right at the top. And it accounts for the phenoconversion and gives you the recommendations based on the phenoconverted status rather than the genotype alone. So I like to end with this. It's not just pharmacogenetics. If a patient doesn't take their medication, which is what is shown here, lots of missed doses, the concentration time curve is not as pretty as all of those models that I showed you earlier. And the patient may not reach that target trough concentration um, uh, because of adherence issues. So pharmacogenetics is not the end all be all. There are a lot of things that contribute to whether the patient's drug concentration as well as their response. So I'll end with the reiterating that psychotropic medications are metabolized by polymorphic enzymes, and pharmacogenetics can be used for adjusting the doses of medications, but shouldn't be used for medication selection. And there are quite a lot of resources out there for clinicians to understand pharmacogenetics. There are quite a lot of people involved in the data I showed you, and that was us at the PGRN meeting last year. So I'm happy to take any questions in the few remaining minutes that we've got.
Thank you, Dr. Ramsey. That was a fantastic presentation, super informative, and it did generate some questions. So maybe we could take one or two questions and follow up with the rest. So
Sure.
first question is thanking you again for the informative presentation. Some of the psychotropic drug metabolites may undergo further metabolism through CYPs other than 2C19 and 2D6, which polymorphisms may impact drug activation and clearance. Are the efforts to integrate additional PGX info to help tailoring or optimizing therapy in individuals with polymorphisms in multiple CYPs?
Yeah, when the data is available, CPIC will certainly take that into account. And so it's difficult to find those populations, especially in kids, but there are the TDM service in Europe. They have been a source of a lot of those very large scale studies to show the concentration effect and include testing of multiple genes. So they are at the sort of the best place to evaluate that. And when that evidence is out there, then CPIC will surely include that and be able to use multiple genes.
Wonderful. Thank you so much. I have another question. Excellent lecture. Could you maybe comment on the challenges of pharmacogenomics and polyform pharmacy?
Yeah, absolutely. The drug-drug gene interactions that I showed you are much more common in adults than they are in kids. So but the prescription of fluoxetine and risperidone especially is very common in the US. So that is definitely something. It was in the drug label, but even the clinicians that were prescribing in Cincinnati when we looked at the electronic health records weren't accounting for that when they were dosing the medications. So it's certainly something to consider. It's difficult to do with electronic alerts and kind of trying to let the provider know. Not all of the care happens at one. We don't have, universal health care to be able to see the records from other places all the time. So it relies a lot on the patient reporting what medications they're taking, but that certainly needs to be taken into account.
Wonderful. We had a couple more questions come into the chat, but maybe we can maybe formulate one last question for you and maybe get your thoughts on PGX testing in clinical practice. Like, when will it become routine? What about standardization? Can you maybe talk a little bit about that?
Yeah. There have been a lot of implementation studies recently, and the studies in Europe, they enrolled over 7,000 people and showed that pharmacogenetic testing with a panel really reduced the adverse drug reactions across the board by 30%. So really, I think that is the kind of data that we need to convince insurance companies to cover it, convince the clinicians that it's helpful, and that is the the data that's really more needed to improve the implementation and the clinical acceptability.
Wonderful. Dr. Ramsey, this was great. As always, I always look forward to your talks. This was really helpful information, and I think it's an area that, many of us aren't exposed to. So it was really nice to get some more information in this space. So thank you again for your talk today.
Yeah, thanks for having me.
Absolutely. And we'll definitely have you back.
Great.
All right, so I just want to close out and thank you all for attending, and thanks to our wonderful speaker. Our next lecture will be Wednesday, January 21st. It's entitled Pharmacogenomics of Drug Toxicity and its Clinical Implementation. Excuse me. This talk will be given by Dr. Jun Yang of St. Jude Children's Research Hospital. Again, thank you for your attendance. Thank you to our wonderful speaker. I hope you all have a great rest of your day.
Thanks, Leslie.
Thanks.